Neurology Quiz number 92. Discuss the clinical features, pathophysiology and treatment of diabetic lumbosacral radiculoplexus neuropathy or DLRPN. DLRPN is a monophasic neuropathy in diabetics that can present over weeks or months with lower extremity pain, weakness and atrophy, which is often more proximal and asymmetric. Other names for the condition include diabetic amyotrophy and Bruns-Garland syndrome. Incidence in population studies is reported to be 4 per 100,000 per year, making it more common than other neuropathies such as AIDP, CIDP, Parsonage-Turner syndrome, among others. It occurs most commonly in patients with type 2 diabetes, who are usually more than 50 years of age, with the median age of onset being 65 years. It is more common in men and is often associated with weight loss, usually more than 10 pounds. Patients present with acute and severe pain in the hip or thigh unilaterally. The pain is often described as burning with increased sensitivity. Pain can spread to the entire limb or contralaterally. Initially, the pain can be quite debilitating and patients may require assistive devices such as a walker or a wheelchair for ambulation. Pain is followed by weakness, which is initially often proximal and then spreads to the entire limb. Sensory loss is typically not part of this condition, but patients may have underlying diabetic polyneuropathy with associated sensory loss. Pain usually improves first, and if the patients are seen later in the course, they may only have weakness and atrophy in a limb with loss of knee and ankle jerks. Eventually, most patients report improvement in strength. Although this is slow and delayed, can take up to 2 years and is usually incomplete. Some patients will experience a subsequent episode on the opposite side. This figure shows proximal muscle atrophy in a case of DLRPN. Pathophysiology. Unlike the more common distal symmetric polyneuropathy and diabetes, DLRPN is not directly related to hyperglycemia and the metabolic syndrome. In contrast to patients with DSP, these patients often have good glycemic control. Pathologic data suggests that it is caused by microvasculitis leading to ischemic nerve injury, which affects the lumbosacral nerve roots, the lumbosacral plexus, and the peripheral nerves in a multifocal pattern. This figure shows the lumbosacral roots, lumbosacral plexus and branches, which is the site of involvement in this condition. This figure shows a case of DLRPN and superficial peroneal nerve biopsy showing evidence of inflammatory neuropathy. Figure A shows a teased fiber preparation with fibers undergoing axonal degeneration. Figure B shows an H&E stain showing epineurial perivascular inflammatory infiltrate. Figure C shows inflammatory cells that are reacting to CD45 immunostaining. Diagnosis. This is primarily based on the characteristic history and clinical examination. EMG and nerve conduction studies can provide evidence of involvement of the roots, plexus, and peripheral nerves on the affected side. Biopsy of an affected nerve can show focal or multifocal nerve fiber loss, perivascular mononuclear cell infiltration, segmental demyelination, and axonal degeneration. Nerve biopsy is usually not required for diagnosis. CSF examination shows elevated protein indicating involvement of the roots. MRI of the lumbosacral plexus can show increased T2 signal intensity and thickening of the nerves. MRI of the lumbosacral spine is usually normal but is often performed, as the differential diagnosis for this condition includes spine and disc disease. Because of the proximal muscle weakness, muscle disease is often considered in the differential diagnosis, and lab tests such as CPK are ordered. This figure shows an MRI in a case of idiopathic lumbosacral plexopathy. This is a T1 weighted image with gadolinium, which shows increased intensity of the lumbar plexus on the left side. A similar appearance can be seen in DLRPN. Treatment centers mainly on symptomatic treatment of pain, management of hypoglycemia if present, and improvement in mobility. Pain can initially be treated with Tylenol or NSAIDs. For more severe pain, options include gabapentin, Lyrica, amitriptyline, and SSRIs. In patients with unremitting pain, pain management consultation as well as admission to the hospital should be considered. Mobility can be improved by providing adaptive devices such as AFOs, walkers, and wheelchairs. Immunotherapy. Despite the evidence of an immune basis, limited data is available to support the use of immunotherapy in management. The results of one small randomized study suggested that IV methylprednisolone can improve pain in patients with DLRPN, but there was no significant difference in the functional outcome. Early studies with intravenous immunoglobulin did not show any evidence for significant or consistent benefit.